Good morning, ladies and gentlemen, and welcome to Stone. We're very pleased to have Jill Kron with us today, and I will do a little more formal introduction in a moment. So, if you are able and willing and would like to join me in the land acknowledgement, please do so. The Creator, overflowing with love, breathed all creation into being.
God made people to care for the earth, God's creatures, and each other.
We acknowledge that the land on which we live, work, and worship today is the land traditionally cared for by the Anishinaabe, Adawandron, Haudenosaunee, and Métis peoples.
When our ancestors came, they imposed practices of land ownership that led to broken relationships.
We acknowledge the enduring presence and deep traditional knowledge, laws, and philosophies of the Indigenous people with whom we share this land today.
We long for reconciliation with our Indigenous siblings so that together we can care for creation and share the land and the earth's resources as the Creator intended.
So it is my distinct pleasure to introduce my pharmacist, Jill Kron. Jill began her pharmacy career in high school, because she was mentored by, most of you will know, or some of you will know, Mary Morrell and Maya Dale. And good experience in mentorship, and then she went on to pursue, after high school, her university, and started her career in pharmacy at the University of Toronto in 2008. So that's a little fact that I didn't know about Jill. Following that, she completed a year of specialized hospital pharmacy training at St. Joseph's Healthcare in Hamilton. Then went to the Guelph General Hospital for 10 years as a, in quotation marks, hospital pharmacist, but I rather suspect she was all over helping patients and doing all sorts of things and keeping her colleagues and doctors in line. So, very dedicated pharmacist. She's been dedicated to practicing and promoting safety initiatives, clinical pharmacy practice, of course, and then just the way she was mentored, student mentorship. So, as a lifelong resident, Jill has given back to the community in so many ways, and so we welcome her here this morning. Jill, welcome.
Thank you so much for the invitation today. I was actually quite honored to be asked to present. This is a very important topic to me. I'm quite passionate about the clinical practice of pharmacists in our province. So I hope I can provide quite a bit of information for you today. I do have a lot of information. I'm going to try my best to keep it to 45 minutes, but I sometimes get going and get excited. So I've got my timer. So I'm here today to present on primarily the new scopes of practice for pharmacists here in our province of Ontario, but I've also included some other really important information about clinical pharmacy practice as well. So today you're going to get to meet Mary. Mary is a real-life patient of mine. I have changed a few details about Mary, just for her personal confidentiality, of course. But I'll be walking through 3 different clinical practices that pharmacists have authority to provide for our patients in this province. The first being the Ontario Meds Check program. I actually decided to include this just the other day, given the recent media attention that has been brought forth about the Ontario Meds Check program. I'm not sure if anybody has been listening to the news about that, but I can address questions about that as well. But I'll be providing information about Mary's Meds Check. Some information about our new scope of practice to inject medications in our pharmacies, in addition to the vaccines that we're already able to provide, as well as, of course, I'm sure most of you have heard about Ontario's new minor ailments program for pharmacists assessing and prescribing in Ontario. So this is Mary. This is actually a pretty close representation to Mary. It's funny. Her and I met in September of 2020. I don't know if you can even remember this period of time in your life. It was right in the heat of the pandemic, and we were one of the only places open at the time. So really one of the first places to access healthcare during the pandemic at this point in time. And Mary and I met at the UPS drop-off location, which is also kind of funny because we have a lot of really interesting conversations about, when you're dropping off your UPS package. But She had just moved to town and had moved in with her daughter to help with childcare. There was no daycare and no school at the time. She decided to transfer her medications to our pharmacy because we were now the most accessible and closest location for her to access healthcare, as she had moved from over 2 hours away. And Mary did what we like best. She asked a question. And she said to me at the UPS drop-off location while we were managing the medication transfer, she said, you know, I've got a question about stopping one of my medications. Do you think we could talk about it at some point in time? So we love questions. And so I seized the day and booked in a meds check appointment with Mary. I'll be quite brief with this part, but I just really, the goal of reviewing Mary's meds check with you is just so that you can realize the value as a patient for what a meds check can offer. So just a quick history about the meds check program. It was actually introduced in 2007 in Ontario. And it's a way for a patient to have a one-on-one consultation in person with their pharmacist. You're actually eligible every year as long as you're taking 3 chronic medications or you have type 1 or type 2 diabetes. So you can visit your pharmacist every year and do an in-depth review of your medication regimen. We tend to book appointments for these unless there's something that's critical and urgent going on in that moment. And actually any person in the province that has a valid OHIP card is eligible. So at any age, you can come see your pharmacist. So that includes children as well, that, for example, have diabetic regimens and so on. And of course, the overall goal of the meds check is to build a mutual understanding between your pharmacist and the patient about their medication regimen, and to identify and work to resolve any actual or potential drug-related problems. So has anybody heard the news recently about the whole buzz? Okay. Yeah, so there's been some information in the media talking about how meds checks billing to OHIP has been inappropriate in our province. I won't get into a lot about what I know about that, but certainly our goal, as most pharmacists have a goal in the province of providing quality, value-added meds checks, that would be our ethical responsibility to our patients. So as a pharmacist, you know, we actually view these interactions as quite useful. So I'll be brief again about Mary's history because this lends kind of into the presentation. So this information is kind of important for later on. But Mary is a 69-year-old female. She's a slim build. She quit smoking 30 years ago. She doesn't currently use recreational drugs like marijuana, and she doesn't really exercise a whole lot. In the past, she was diagnosed with hypothyroidism. So that's a low functioning of your thyroid gland, sorry. She has been diagnosed 15 years ago with rheumatoid arthritis. Unfortunately, 5 years ago, her husband did pass and she experienced an episode of depression in that period of time. And recently, she's been diagnosed by her family doctor with osteoporosis with a high risk for fractures. Of course, the meat of it is all about medications when you're a pharmacist. So this is her medication history. She takes a thyroid hormone supplement called levothyroxine, and this is monitored and hasn't really changed a whole lot in the last few years. She also takes 2 medications, methotrexate and folic acid for her rheumatoid arthritis. The medication she's interested in stopping is called sertraline. This is a medication that we use for depression. And she recently purchased some calcium and vitamin D at the grocery store over the counter to begin treatment for osteoporosis on advice from her family doctor. As well, Mary receives an injection every 6 months called Prolia. It's a subcutaneous injection, and that's to help prevent the risk for fractures. So do not expect you to remember all that. That's my job. But this is important for discussions later on in my presentation. And as I did mention, Mary is over a 2-hour drive from her family doctor and her rheumatologist. So we automatically, in this moment, become her closest healthcare provider. And that's a 2-hour drive there and back. So it's a 4-hour round trip. There's a number of interventions pharmacists do on a routine basis. We always check for drug interactions. But this drug interaction stood out for Mary. Taking levothyroxine and calcium together can impact the ability of both medications to be absorbed into the body. So she was at risk of having uncontrolled hypothyroidism. We immediately, I identified that and had that discussion about timing of administration for medications. On the bottom, you can see one of the drug interaction checker software images that we use. We actually have 3 different ones at the pharmacy that we pay for annually. We check for drug interactions every day, all the time, but we can often do a more in-depth check when you're sitting with us for a medication review. I was also able to send a pharmaceutical opinion for Mary. So a pharmaceutical opinion is basically a glorified name for a recommendation. And I was able to send one to her rheumatologist about her folic acid medication. She'd actually been buying it, funny enough, over the counter without a prescription. So she was paying a little bit of money to have this medication at home, but it can be prescribed, covered by the Ontario government. And she was also taking 5 tablets all at once to get her full dose of 5 milligrams. So we have a 5 milligram tablet available on prescription. I was able to send that recommendation to her rheumatologist for review. And then finally, of course, we had to address the question that she initially came in for anyway, which was stopping one of her medications. So not only are pharmacists experts at initiating medications and managing drug therapy, we can help you stop things too. And I was able to also send a pharmaceutical opinion to her family doctor about stopping her depression medication. They already had a conversation about it, but I was able to tell or suggest a way to actually do it, to minimize her risk for adverse effects associated with potential withdrawal. So, and then finally, actually another thing that our patients don't really realize that we do quite a bit as well, is I was able to adapt her sertraline, her depression medication prescription. So pharmacists in the province can actually change a prescription that we receive from a prescriber, and we do that quite frequently. So we can change, for example, the format of a medication. We can change it from a tablet to a liquid. We can change the frequency at which you take a medication, so if it's better suited twice a day versus once a day. So we can do that as well. In her case, I adapted the dosage format from a 100 milligram capsule to a 25 milligram capsule, so she'd be ready and prepared to discontinue that medication when the time was right. So again, this is a really quick overview of some of the types of things that can come of a meds check. And in Mary's case, we were able to avoid a very relevant and potentially detrimental drug interaction before it even happened in the first place. She hadn't started her calcium yet. She was sort of waiting to get things settled at her daughter's place. But you know, this kind of a drug interaction can take a lot of time to fix. A lot of time invested by your physician, reviewing lab work, a lot of visits to the lab for a patient to have blood work drawn. So avoiding drug interactions is actually quite ideal. And then the physicians that I interacted with both accepted my pharmaceutical opinions. We were able to get a new prescription for Mary for her folic acid, and we were able to stop one of her medications very successfully over the next several months. So this all happened in September of 2020. So I had to review all my notes actually to remember all this stuff, but it was a very successful meds check for Mary. Does anybody have any questions about this program that pharmacists are able to offer? I hope some of the audience has had a meds check before. We as pharmacists view this very much as you would an annual review with your family doctor. This is an annual review for your medication use. So don't hesitate to contact your pharmacist or your pharmacy team and see if you can get yourself booked in. So the next piece of my presentation, and Mary will follow us through into this section as well, but the next piece of my presentation is in regards to a new scope of practice that was introduced last July for pharmacists in our province. So we've always been able to administer vaccinations. I think probably most people here know that. But now we're actually able to administer medications themselves in the pharmacy. Prior to that, or historically, there was a lot of red tape that a pharmacist had to go through to be able to administer a medication. So not a vaccine, so they're two separate things. So vaccines we've had authority to provide since 2016. but actual drugs we can now administer in our store. So it's really great because we can initiate these interactions autonomously now, which has been very beneficial to a number of our patients. Before I follow Mary into her medication injection piece, I did also want to touch on on something that I get questions about almost every single day. So this is a bit of a side note, but this is about vaccinating, and this is about vaccinating in Ontario. Every province does have their own way to provide vaccinations. And this is just a brief overview so that maybe you have a bit of a better understanding yourself when you're trying to access vaccines in this province. So as most of you know, there are many publicly funded vaccinations, but there's also sort of the privately funded vaccine stream as well. Publicly funded vaccines, of course, include all the vaccines that you receive in childhood, like MMR. That's another big one that's in the news right now. But it can also include things like Shingrix, so a vaccine that helps to prevent shingles, and you're eligible publicly for that vaccine between the age of 65 and 69. Other things like tetanus, which you should get every 10 years. So these are vaccines that are paid for by the Ontario government, and you're able to access those through your family doctor. Pharmacists are not able to administer publicly funded vaccines, with 2 exceptions being COVID-19 and influenza. Privately funded vaccinations are ones that are paid for through either out-of-pocket payment or vaccines that your private health plan pays for, either through work or one that you pay for. And they can be purchased at your pharmacy, and they can either be administered by your pharmacist on site or by your family doctor as well. So I get a lot of questions about this almost every day. Just basically, this slide is for you to know that there's different ways to access vaccines. Pharmacists are very well suited to answer questions about this, so feel free to ask at any time. And then I have a little piece about pharmacy technicians, and I can talk, actually that's probably the wrong stuff, I can talk about that in a bit. Is there any questions about vaccinations in Ontario? Okay. So we'll move back then to Mary. She's been able to thankfully access both of those publicly funded vaccines through our pharmacy. She's unique in that she's immunocompromised because she takes medications for her rheumatoid arthritis. She, through the pandemic, had a very different vaccination schedule from the general public, and we were thankfully very pleased to be able to help her navigate that vaccine schedule. And then of course she does receive her annual influenza vaccination from us as well. And last fall, when I gave Mary her flu shot, she asked me another question. And she said to me, why, Jill, why just can't I get all my injections from you? Why can't I get both vaccines and medications as well? And so that moves back into that regulatory change that I mentioned from last July. So pharmacists are now able to administer medications in the pharmacy. This is important, actually, and it may not be as important to you as it is to me, but this was built right into our Pharmacy Act, which is the legislation in Ontario that lets pharmacists do what they can do. Basically, it regulates our practice, and they very rarely change the Pharmacy Act, and we've had 2 changes now in the last 12 months. So this is actually fairly significant. And as I mentioned, we no longer need to jump through hoops to be able to provide an injection to a patient for a medication in our practice. On this side, on your right-hand side, is a list of all the medications that pharmacists are now able to provide in store. So you can receive any of these medications from your pharmacist now. And on the left is actually sort of a list of all the different vaccinations that a pharmacist is also able to provide. Again, that's an older list from 2016, so we've been doing that for a long time. But on the right-hand side, this is the new and exciting piece that a pharmacist can access. So again, there's no test at the end of this presentation. So you don't have to have this memorized because I don't either yet. But when Mary asked that question, I was able to bring up my list. And funny enough, there's a medication on this list that is denosumab, which is the generic name for Prolia. So now Mary is able to actually access healthcare from myself in the form of this medication being injected in our pharmacy every 6 months. She no longer has to make the round-trip drive to her family doctor, which is, really beneficial to her. We do schedule appointments for injections, whether they be vaccines or medications. Oftentimes you're asked to fill out well, actually every single time you're asked to fill out a consent form in advance for obvious reasons. And most pharmacies do charge a service fee to receive an injection, aside from the 2 publicly funded injections, which are COVID-19 and influenza. And the reason for this is because it does pay for our time, our staffing, and our supplies that are required. You may ask why your family doctor doesn't charge fees. They do, they just charge them to OHIP. So it's not an out-of-pocket expense per se. So Mary's very, very happy. So we did her first Prolia injection this past fall, and then she's scheduled 6 months later for her next injection. So if you are receiving an injectable medication, feel free to ask your pharmacist if that's something that you're interested in doing to improve your access to healthcare. Is there any questions about injections?
Do you think they'll change it so that you can charge it to OHIP down the road? Like, it just seems like a double standard that...
Yes, yes, I hope so. Our advocacy bodies are working very hard on things like that. It doesn't make sense, I agree. We don't have billing numbers through OHIP per se, and so that would have to be in place in order for us to be able to do that. We work out of a different funding stream from the Ontario government. Yeah, great question. We were hoping to see something about that when they introduced that legislation in July, but unfortunately, not yet. Any other questions at all, or quiet crowd? Okay. So this is probably the information that you're here for today, which is more information, or which is the piece of the presentation I'm hoping to give today about the Ontario Minor Ailments Program. So I'm not sure if anybody's accessed this program yet, but I'm hoping to walk through Mary's journey through the Ontario Minor Ailments Program to give you some more information about how to access it, what the program looks like, and what kind of outcomes you might expect from having a minor ailments assessment by your community pharmacist. I'll start with the background on the Ontario Minor Ailments Program, and then we'll move into the case examples with Mary. She's actually accessed this program 3 times since January of 2023. So in January of 2023, the Pharmacy Act was changed as well to include the minor ailments prescribing and assessing program for pharmacists in our province. It was also changed again in October of 2023. So this was a lot to take in last year in 2023, especially after we've gone through so many changes in the past 2 years with respect to our practice. But pharmacists have been well suited to implement this kind of program. We've been asking for it for 20 years, I believe. So, a really, really exciting time to be a community pharmacist is right now, because this has been a long-awaited program, basically. So pharmacists were granted the authority to assess and prescribe. Please pay attention to those 2 words because they're very important. Pharmacists are not able to diagnose, so we are not able to diagnose any health condition in this province or really across the country. And I'll go into a little bit more about that when we're talking about Mary's cases. The implementation of this program was a joint effort between many different stakeholders, so our professional associations, our College of Pharmacy, the medical professionals, so many physicians, as well as patients themselves. And of course, as we can all imagine, the goal of the Minor Ailments Program was to ease the burden on the healthcare system. I think we all probably can understand that that's an issue today, as well as improve access to healthcare for many of our patients in Ontario, and improve patient outcomes, so potentially being able to receive healthcare a little bit faster. This is a program that is funded by OHIP, to go back to your question, but again, it's funded sort of in a different stream, and that's a whole other presentation, so we won't go into that. in a lot of detail, but the importance is that you can access this program without charge, without fee or out-of-pocket cost to yourself. So what is a minor ailment? So this is the definition that we worked from when we decided what would be included in this program. So a minor ailment is a health condition that essentially requires a minimal amount of treatment. It's not a 911 type situation. It doesn't require treatment in this immediate moment. And generally these conditions tend to be short-term in nature. Lab results usually are not required, or by definition are not required to be able to be included in the minor ailments program. And these minor ailment conditions have a low risk for masking any other underlying health condition that might be more significant or serious. And minimal or no follow-up is required after a minor ailment is assessed by a pharmacist. And finally, there are no, this is a medical term, but red flags. A red flag is something that, well, it's like a red flag. You put it up, you wave it in the air, you've identified something, and you need to stop immediately and move on to referring a patient to the most appropriate healthcare provider. So this is what the definition that we use to begin including these 19 different minor ailments in the pharmacist assessment and prescribing program in our province. So as I mentioned, in January of 2023, there were 13 minor ailments that were introduced into the legislation. 9 months later, after a massive uptake of this program across our province, the Ontario government recognized that it was quite successful, and they added an additional 6 minor ailments to the program in October of 2023. To go through each of these minor ailments today would take forever, and I don't think any of us have that time. So I'll be using Mary as a case-based example for 3 different ones. And many of these may not be relevant to my audience today either. This program, I was just actually reading a statistic this week that 94% of pharmacies in Ontario have now participated in this program. So it's been hugely successful. And I think people are really starting to recognize the value of the pharmacist in accessing healthcare. Another really important point is that the Ontario government didn't require pharmacists to undergo any education or training in addition to what they already do in their university educations. We were thrilled with that because it really validated our knowledge and expertise. So we do this stuff already anyway, every day. It's just now it's a bit more formalized into a program. Does anybody have any questions so far about the minor ailments? Yeah.
Can I just ask about Lyme disease prevention? I didn't know there would be a prevention for Lyme disease.
Yeah, so I actually do touch on that very quickly at the end, though.
Okay.
We can talk about it now because you brought it up. So Lyme disease is actually a bacterial infection that's caused by a bacteria that live in the mouthpieces and the gut of a tick, black-legged ticks specifically, or deer ticks they're also known as. And there are parameters for which pharmacists are able to prescribe an antibiotic to try and prevent Lyme disease should you have been bitten by one of these ticks within a certain period of time. Yeah, does that help answer the question? Yeah. So this is actually quite relevant. I did a ton of these assessments last summer. Unfortunately, we live in an area now with black-legged ticks. That's the reality of it. And so there's black-legged ticks here and dog ticks, but roughly a 50-50 mix. Some years it's more, some years it's less. So yes, Lyme disease prevention is going to be big, unfortunately, probably again this year as well, especially given the weather and so on. So, is there any other questions about this massive, daunting 19 list? In Ontario, we've been fortunate enough to have access now to these 19 minor ailments for assessing and prescribing. Across our country, pharmacists have been assessing and prescribing since 2007. Ontario is very late to the game, which is why we've been advocating for this program for 20 years. In fact, on the East Coast, Pharmacists are able to assess and prescribe for 35 to 40 minor ailments. In fact, they actually have clinics that are pharmacist run only. There's just a pharmacist there, and that's all they do is assess and prescribe all day. And actually, I was able to see that in person in 2022 when my mom and I traveled to the United Church Women's 60th anniversary in St. Nova Scotia. I saw that firsthand. It's exciting to see. So that is potentially the future of the minor ailments program, but fingers crossed for the future. So, just a quick note about the medication. So, of course, we do an assessment and we are able now to prescribe for these 19 minor ailments. Just an important note, though, that the number of different prescription-based medications that a pharmacist is able to write a physical prescription for is limited. We have to function, unfortunately, for now, off a list. So just because you come in with a minor ailment and we're able to write a prescription for you for a medication does not always mean that it's the most suited medication to the patient in front of us. And so if the medication, there's lots of different medications to treat lots of different conditions, but it may not be included, the drug that's right for you may not be included on this list, in which case we would have to refer. A really good example of that is urinary tract infections. That writing is super small, but we only have access to 4 different drugs. Well, there's about 20 that you can use to treat a UTI, and so we would make that decision in the moment as to whether we would be able to prescribe the right medication for you. So just our prescribing limits are not all-inclusive, they're not exhaustive. We do, unfortunately, for now, have to function off the list. So back to Mary. She's with her grandson. And this, again, is a very true story. So Mary, in March of 2023, brought her little grandson into the pharmacy. She was looking for me because we had just kind of met. We built a really good relationship. And she asked to speak with me. And she had heard that her pharmacist could now help with stuff. We get stuff a lot. And that's normal, of course, given that this is very new in our province. And she had self-diagnosed her grandson with pink eye. You can see his eyes not looking so great. And she said to me, Jill, do I need to make a doctor's appointment to deal with this, or can you help me with this stuff today? So this is kind of what a minor ailments assessment would look like if you came in to speak with your pharmacist about one of these issues. It's divided into 2 sections. The first section is the pharmacist's assessment. And then the second section is the pharmacist's ability to prescribe. So an assessment is what we did actually in that moment for Mary and her grandson. She had self-diagnosed her grandson with conjunctivitis or pink eye. So I can't diagnose. You do have to kind of come in with some knowledge about what you might be experiencing. And we did a really nice consultation between her and I and her grandson right there in the pharmacy at the pharmacy counter. Oftentimes we do these kinds of assessments in person. However, we can provide these services over the phone as well. So if you're unable to visit the pharmacy, you can always give us a call. The assessment generally takes about 10 minutes, give or take, depending on the situation. And what that assessment does is confirms your own self-diagnosis. So, we also, at that time, assess for any exemptions from the program. So there are reasons why maybe not seeing a pharmacist might not be in your best interest. Or those red flags, which I talked about, in which case we have to refer you right away. And then from there, depending on the outcome of the assessment, we are able to prescribe. And we prescribe a lot of different things. So we can prescribe things that are self-care measures that make you feel better right away. Or we can prescribe over-the-counter treatments. So, we can go out into the aisle and see if there's, something that might treat your minor ailment there. Or as I mentioned before, we can now be a prescriber and write prescriptions for medications. And as I have already alluded to, a pharmacist may actually prescribe a referral. So we very frequently, unfortunately, do need to refer to family doctors or sometimes your optometrist, or there's a whole host of different people that we can refer to as well. But that would also be considered technically a prescription as well. So in Mary's grandson's case, her and I did the 10-minute assessment. I asked questions like, what kind of discharge is coming from your grandson's eye? It was crusty, goopy. His eye was crusted over in the morning, especially when he was waking up. It started in one eye, and then 24 hours later, very quickly transitioned to the other eye. That's another very common symptom for bacterial conjunctivitis, which is kind of illustrated there at the bottom. And he had exposure at daycare. So all of those things kind of lined up, and we were able to confirm Mary's grandson's self-diagnosis through that assessment. And then from there, as the pharmacist, I become a prescriber. So not only did I prescribe a prescription antibiotic eye drop called tobramycin, which is only accessible through prescription, but I was also able to talk to her about some self-care measures that she was able to implement, like a warm compress to remove the crusts, the reducing risk of cross-infection between individuals in the same household, like separating towels, and we talked about him returning to daycare within 24 hours, which she was very happy about as well. So, you know, it was actually really, really beneficial for her, as well as her grandson. She accessed care right away, and she didn't have to wait, so it was great. Another important point to discuss with respect to pharmacists prescribing is now that we are the prescriber, just like a doctor or a nurse practitioner, that prescription can be filled anywhere. So we can actually send your prescription that we've written at the pharmacy to any other pharmacy of your choice. So that's a kind of an important distinction. You'd often think maybe you need to have it filled there or whatever, but you could call me from Grand Bend because you're on vacation this summer. We could conduct a minor ailments assessment, and we could send that prescription to a pharmacy closer to where you are. Another important part of the minor ailments program for pharmacists is the follow-up piece. I mentioned earlier that most minor ailments require minimal to almost no follow-up at all, but we do provide follow-up anyway. So we will send all the information from the assessment, all the information about the medications prescribed to the family doctor. So we do that formally in a consult note. And then we also will schedule, most often, a follow-up phone call. That's typically what we've been doing anyway, but you can visit in person as well. And this phone call really just is in order to assess the outcomes of the interventions we've recommended, making sure you're not having any adverse effects associated with the medications that have been prescribed, and just, of course, to answer any of the questions you might have. The follow-up call is always relevant to the time period for which we would expect improvement of the minor ailment. In conjunctivitis, we often call 48 hours later. If you're having a minor ailments assessment for dermatitis or GERD, like reflux, or allergic rhinitis, so allergies, we might call in a couple of weeks to see how you're feeling. So there he is, off back to the daycare, happy boy, happy grandma. I'm just going to check the time, make sure. Okay. So Mary's minor ailment assessment, her second assessment, actually came into the fall of last year. And this is actually an important assessment to talk about because it does illustrate some of the limitations of our program. So Mary called the pharmacy. I wasn't there that day. She did end up speaking with one of my colleagues. She asked to speak to the pharmacist. And she, of course, described feeling the constant urge to have to go pee. And it was burning slightly and very uncomfortable. She had been diagnosed in the past with urinary tract infections, was very familiar with the symptoms, and had self-diagnosed herself with a urinary tract infection. And of course, her question was, do I need to make a doctor's appointment? This is pretty much the standard question we hear all the time. And she didn't want to travel, of course, travel far. So, can you guys still hear me? Okay. The pharmacist on duty that day did end up taking the phone call and having a chat with her, and at the same time reviewed her medication history And in the past 9 months, Mary had been already treated for 2 urinary tract infections. And of course, she's immunocompromised. If you'll recall, she's on medication for her rheumatoid arthritis called methotrexate. And this medication results in a person being immunocompromised. So immediately, my colleague was able to identify that unfortunately, Mary would not be eligible for a minor illness assessment in that moment. So on this slide here, it illustrates one of the algorithms that we do follow to identify red flags. Urinary tract infections and tick bites are actually the 2 algorithms that we use the most. But of course, in Mary's case on this list here, you don't have to go through it all. I've highlighted the red flags for you. But she is immunocompromised, and this is her 3rd urinary tract infection in the last 365 days. So she is immediately not eligible for a minor illness assessment by a pharmacist. And in this case, my colleague prescribed a referral to her family doctor, unfortunately. Some other red flags, just as examples for you to kind of understand the program a bit better, would be if you have male anatomy, if you're under the age of 12, if you're pregnant, of course, or if you've had a relapse, so this is your 2nd urinary tract infection in the last 4 weeks. Or of course, if you have symptoms like fever or back pain, chills, that could indicate an infection in your kidneys. And the 4 antibiotics that pharmacists are able to prescribe would never treat a kidney infection. And so we would have to refer you immediately to a family doctor for a more further assessment. So with this case, I just wanted to illustrate, unfortunately, some of the limitations, but it still means that you can access care right away, and your pharmacist is able to send the results of the assessment to your prescriber. So they may be thankful for that information because they have a bit of a heads up in terms of what's going on, and it might improve your access to care a little bit faster. Does anybody have any questions about that piece?
What do you do if the patient doesn't have a family doctor and you can't prescribe? Who do you refer the patient to?
Great question. So this is a big problem right now in our province. Most people are probably familiar, even in our own community. We've had 2 family doctors retire or move on in the last 3 months. So we have, what is the statistic? Is it 1,200 patients in our community without a family doctor, I think? That could be wrong. It might be more. So we have to refer to a walk-in clinic. Yeah. So we have a list of walk-in clinics, of course. And fortunately, actually, we do have access to walk-in clinics in Southern Ontario. You might not always have access if you're in Northern Ontario, or it might be a 1-hour drive to see the nearest physician that can see you. So that's one of the reasons that minor ailments assessing and prescribing is very valuable in the northern communities for those patients. But yeah, unfortunately, if there is no family doctor, if it's a condition with the eye, I often refer to the optometrist because they can actually do a lot as well. But if there is no family doctor, then we have to unfortunately go to the walk-in clinic. Yeah. Or if it's a 911 type situation, obviously to emerge or something like that, which is not always ideal either. Great question. Oh, was there another question there? Okay. So unfortunately, with respect to this minor ailment, we did have to refer, as I've already mentioned. Mary's current presentation is outside of the scope of the program for the minor ailments assessment and prescribing, and she did unfortunately have to make the trip to her family doctor. So that was too bad we couldn't help her, but we definitely tried. So, the 3rd minor ailment happened at the end of this past January, so about a year after the inception of the program. And Mary is very familiar with minor ailments, assessing and prescribing now. She's accessed it twice now before from her pharmacist. And she called, she got me on the phone, and she asked if we could now book an appointment. So we do book appointments for non-urgent minor ailment assessments. It doesn't always have to happen right in the moment, because not all situations are urgent. A good example of that would be actually something I've already mentioned, which is dermatitis or eczema. We can always talk about that in a one-on-one consultation at a later time. And that's exactly what she suggested to me. Can we talk about this next week? It was, I think, Friday afternoon at 4 o'clock. That's when everything happens. So, so it just wasn't a good time. So we booked an appointment for the following week. And she was experiencing classic symptoms of what she had self-diagnosed herself, which was allergies. The grandkids got a new puppy dog for Christmas. True story. And she had an itchy nose, her throat was driving her nuts, nasal congestion. And unfortunately, the nasal congestion was causing postnasal drip. So the secretions were dropping down in the back of her throat, and she was coughing all night. And she'd lost weeks of sleep due to this little dog. So she said, I can't sleep, please help. Of course, her and I sat down, we conducted a minor ailments assessment. It didn't take too long, about 12 or 13 minutes. And we did, through questioning, confirm her self-diagnosis of something called an allergic rhinitis. Essentially, this is also known as allergies. She'd already tried a couple of things. She tried some Claritin and some Reactin. She didn't really think that either of those two things had worked. She'd taken the occasional dose here and there. She found the Reactin made her quite drowsy, which she didn't like, which can happen even though it's marketed as a non-drowsy antihistamine. And she'd also tried one of those decongestant nasal sprays that she just picked up over the counter. She'd used it for a couple weeks. Didn't really think it was working all that well. And so she discontinued it, and in fact, it made her symptoms even worse, which is why she was calling, which is something that can happen with prolonged use of over-the-counter nasal decongestant. So as you can see, there's lots of value in going through this kind of an assessment with the patient, because ultimately it does provide insight into the kind of solutions we can provide for our patients. So we did move into the prescribing portion for Mary. And I was able to prescribe a nasal saline rinse for her before bedtime every night to help reduce those annoying secretions dropping into the back of her throat. So that's just an over-the-counter recommendation, something that anybody can do with self-care, easy to access. But I was also able to prescribe a nasal steroid for her, something called Omeris. I don't have shares in that company. I'm just presenting a case, but yeah, so we reviewed the value of using a nasal steroid to help minimize the inflammation and secretions that come along with something called allergic rhinitis. And then we also talked about using an antihistamine every day. And I was able to prescribe a prescription-based antihistamine for Mary to use called Lexten, which is a third-generation antihistamine technically. And we talked about the importance of using it every day to minimize that risk of histamine release from that dog. We did check for drug interactions. Of course, you remember her list of medications is a bit extensive, so as pharmacists, we always do that. And then finally, we did fill those 2 prescription medications at our pharmacy, but again, she could have had them filled anywhere, at any pharmacy of her choice. So in follow-up, this is also actually very true. I called Mary 2 weeks later. She was cleaning the house. She was feeling so much better. Her symptoms had resolved to about 80%. She was feeling about 80% better, which was a huge improvement for her. She was sleeping now at night. And it was sort of what we expected, given the dog was not going anywhere soon. So, she was doing quite a bit better. And she wasn't having any side effects from her medications. Things were going quite well. This was just a very quick follow-up phone call. Oftentimes they just take a couple of minutes to go over what's going on and how things are progressing. So with these 3 case-based examples, I really hope you can see, or at least I hope they're a really good illustration of how your pharmacists can now really become involved more in your healthcare. I know the list is only 19 minor ailments. We do expect it to grow. So now is a great time to consider your pharmacist as one of your primary healthcare providers. We're easily accessible, and usually you can get us on the phone, so it's great. Quickly back to the 19 minor ailments, I thought I'd go through 4 more just very quickly, just because they may be a bit more relevant to this audience. The first, of course, is something called candidal stomatitis. This is also very commonly known as oral thrush. If anybody's experienced oral thrush before, it's not very nice. We often see this, so it's an overgrowth of the yeast on the inside of your mouth. And we see it very commonly associated with the use of steroid inhalers for asthma or COPD, or even for acute illness. And we can now prescribe medications to treat oral thrush. You don't have to see your physician if you don't want to. And then the next one is called herpes labialis that I just wanted to mention. This is also commonly known as cold sores. So cold sores, the faster you treat them, the quicker they resolve and the less severe they are. So pharmacists are able to prescribe an antiviral medication that can help reduce the severity and duration of a cold sore. Lyme disease, so we've kind of already talked about that, but I do expect a large number of patients into the store this year with Lyme disease, or Lyme disease prevention requests. So treating Lyme disease is different. Preventing Lyme disease is different than treatment. So that's, if we were looking at a treatment course for Lyme disease, you'd have to see your prescriber. That would be a completely different thing. And then finally, something called vulvovaginal candidiasis, which is also known as yeast infections, primarily in women. So you can access your pharmacist for assessment and prescribing in this area as well. Are there any questions about the minor ailments here listed? Yeah?
When you make this prescription or do the assessment of it, do you pass that on to the family doctor?
Yes.
That you have, oh, okay.
Yeah. Sorry if that wasn't clear. So we do send along a formalized consult note, at least that's what we do. That is built into the requirements to be able to provide a minor ailment assessment and prescription. You do need to communicate with the family doctor. Yeah, or the rheumatologist or whoever is within that circle of care, whoever it's important to be included, we would include them in that circle of care and information. Yeah.
Could you elaborate on the difference between diagnosis and assessment, and how specific does the self-diagnosis have to be?
You asked the question, I didn't want to be asked. Good question. So the government has been very clear in their terminology that pharmacists are not able to suggest a diagnosis to a patient. We are not necessarily trained in diagnosis, in the art of diagnosis, which is an art in pharmacy school. We're trained more in the assessment of someone coming in and telling us what they already think they have. So at times it can be difficult to differentiate between those two. So there is also a bit of an art to assessment too. But formally in the province and in most provinces, pharmacists are not able to diagnose. So we can't necessarily tell you what you have. Does that answer the question? Kind of?
Well, I guess the question of self-assessment.
Yes.
If somebody comes in and has kind of a vague understanding, like at what point does it become an assessment versus?
Right. So we do have some fairly specific questions that need to be asked through an assessment for a minor ailment. Most of the time, that really either confirms what the patient sort of thinks they might have, even if it's a vague understanding. So they'll say to me, "Oh, yeah, that's exactly what I have," or "Oh, yeah, I've never heard that word before, but that must be it." Versus a patient who might say something to me like, "Oh, that's not at all what I'm experiencing. That doesn't sound at all like I don't have that symptom at all." So we can kind of differentiate down different pathways based on the answers to those kinds of assessment questions. That's a roundabout. It's a hard question to because a doctor assesses a patient to arrive at a diagnosis, right? So but I have to be very clear that we are not able to diagnose a minor illness condition in this province. So, but our line of questioning is always very insightful and generally helps the patient land on either yes, I'm definitely experiencing this minor ailment, or no, I'm not. So, good question. Yeah, there we go. So that sort of ends the meat of my presentation. I'm right on 50 minutes, so that's great. So really, I guess in summary, what I really wanted to highlight with the 3 different sections of this presentation, having a medication review by your pharmacist on an annual basis, being able to access different vaccinations as well as now medication injections, and also pharmacists now being able to provide minor ailments assessments and prescribing opportunities for patients. I really just wanted to highlight all the clinical services that a pharmacist can offer you. We're not just people that count pills behind the counter anymore. I think most people in the room would know that, but our practice of clinical pharmacy in this province has now come a long way, and we're so excited. Pharmacists have been asking, as I said, for this for years and years. So definitely consider your pharmacist as a tool in your healthcare journey. We are definitely medication experts. We can do a lot more than maybe you would expect. So make sure you ask the question because we might be able to help. This is another summary of all the other things that we can do that I didn't get to touch on today. Other drugs we can prescribe, of course, are Paxlovid for COVID-19 and Tamiflu. Paxlovid was actually the first ever drug a pharmacist in this province was able to prescribe. We do a lot of other things too, like dispense naloxone for opioid overdoses, for illicit as well as prescribed drug therapy. And we're doing all these things every day. I hope some of you have accessed these kinds of services from your pharmacist before. So make sure you have a really good, valuable relationship with your pharmacist because they can really, really be of assistance. So thank you so much for listening to my presentation today. I'd be happy to entertain any more questions that you may have. We can do that formally here or in the back room after as well.
So when I go to my doctor, because I don't have insurance, she very carefully looks through to make sure that we can get the cheapest medication for me.
Yes.
How do you decide which to prescribe, and is there a way to get that note on your file so that you don't have to have the conversation about being broke every time you go to the pharmacist?
Yes. That's a good question. I hadn't anticipated that question. So pharmacists are quite familiar. So there's, of course, 2 different streams of drug coverage. One is if you're over the age of 65, you're covered under ODB, the Ontario Drug Benefit Program. There are a number of reasons why you may also be covered under that program if you're not 65 as well. But we pretty much have access to the formulary of drugs that is covered. Most of the drugs that we are able to prescribe as pharmacists are on that list with a few exceptions. For example, Blexten, so the medication I was able to prescribe for Mary, is not covered under that list. But we have knowledge of that because that's what we do every day. In terms of private insurance, that's a whole other story. But we would certainly work with the patient as best as we can to make sure any prescription that we prescribe would be covered by their plan. And if it's not covered, we can try something else. Yeah. In terms of how to get that on your file, you would want to make sure you ask your pharmacy professionals to make sure there's a note on your file that you don't have your coverage. Yeah. There was another question.
The RSV drug, needle, it is not covered
Right.
by ODB.
Exactly. Yes, unless you live in a long-term care home or a retirement home, yes.
Why isn't it covered?
That's also a really, really good question, and I would love to answer that question. It's the same with the Shingrix vaccine as well. If you live outside of the age of 65 to 69, you're not eligible for that vaccine as a publicly funded vaccine. And unfortunately, the ones that make those decisions are the ones that build that ODB formulary, I do feel it should be covered. Because it's extremely expensive, unfortunately.
Because the government is stating we should have
I know.
it. And even well, I got the shot. And I'm lucky I do have extra coverage. But it only covered half
Yeah.
of the extra coverage.
Yeah. I absolutely agree with you. I think there's actually a lot of, and that's one of the reasons I kind of talked about that publicly funded versus privately funded vaccine thing. There's actually a lot of vaccines that I would love to see that are publicly funded. The RFC or the RSV vaccine is one of them. Maybe we'll get there eventually, once the government sees the value. Vaccines are our best prevention against disease, there's no question. We've known that for many years. Staying out of hospital is the best way to stay healthy. So hopefully, they'll see the value and decide to publicly cover it at some point in time. But I agree with you for sure.
Could I send in the extra to my insurance?
I think you can.
Would they cover it because they've already covered half of it?
You can certainly always make that request. If you can't send it to your insurance, you can use out-of-pocket drug coverage or out-of-pocket drug costs as a tax write-off. And we print tax write-off receipts for everybody all the time, and you can include that in your tax return. So it's one option. It's not the best option. It's something.
Do you take back expired medications, or you're cleaning out an estate and you find drugs and stuff? Can you just go to any pharmacy and drop those off?
Yeah, so my lovely colleague Emma will attest to that. So Emma worked at the Rocky Pharmacy for many years. And yes, we do take, it's called the Take Back program, I think, or something like that. But we have large bins in the back of our pharmacy that are away from the public access, obviously. And we just dump all expired medications or unused and unwanted medications back there. Emma has done that many times. And we send them off for incineration. They get incinerated. Yeah. So anything you don't want, just bring it back to us and we'll get rid of it for you. We all have sharps containers too. We do the same thing with sharps. So, yeah.
So I'm a case study. I'm forgetful patient X. And Saturday afternoon, about 4 o'clock, I decide that I don't have any more tablets of whatever medication. So I run down to the local pharmacy and I say, oh I forgot, I don't have any renewals. What do you do with it?
I didn't touch on that in the presentation, but we do that all the time. You can see prescription renewals there is on my summary of things we do. So absolutely, pharmacists are able to, I guess in theory, that was actually the first prescription we were able to provide in this province. It was a renewal on a patient's medication that is a chronic medication only. If you're taking a thyroid tablet for low thyroid, you run out, we might, depending on the circumstance and our clinical judgment, be able to extend that prescription for you. If your thyroid levels haven't changed in 20 years, we'd probably give you another 3 months. If we see on your file there's been changes in the recent past and it might be time to get some blood work, we might only give you 30 days. And we would communicate that with your doctor as well, what we've done. Throughout COVID, we were also able to extend prescriptions and still are for opioids, controlled drugs, and narcotics and stuff like that. We were never able to do that before COVID. But that was one of the many implemented changes that was so hard to keep up to through COVID. And that was obviously designed to prevent patients from going into opioid withdrawal who weren't able to access their family physician. So yes, if it's Saturday afternoon, 4 o'clock, that's exactly the time we see everybody walk in the door with those kinds of situations. Yes, your pharmacist may be able to assist for sure. We often do try to connect with the initial prescriber first, and that's kind of required, but also a courtesy as well with our physician colleagues. So that is why we do fax for refill requests and stuff like that, but if you're in a bind, we can certainly usually assist, for sure. Yeah.
So that brings me to the second question, Jill. How do you keep track of all this stuff, like your data records? Because it follows the mind how much you would have to keep track of. If I'm in a doctor's office, they just bring up my little chart, let's check here, or red flag this. So I'm presuming you have something.
We are chart 2. We have a software called Kroll, if you're really excited to learn more. So it's a paid software. Of course, we have a monthly subscription to that. It's all confidential. It's highly guarded and all that kind of stuff on site in our pharmacy. And I actually show this to everyone that comes into a meds check, for everyone that comes into a meds check, so they understand what we see. So I show that. And we have a file for every single patient with all their information. We can include lots of different kinds of notes about drug coverage. And if you go to the same pharmacy all the time, like many of our clients do, we can see back years and years and years and years and years of drug treatments. That's actually quite a valuable tool. I can see, I prescribed for a urinary tract infection last night at 6:30. I could see that the patient had previously well tolerated an antibiotic in the past 2 years ago. And she said, yeah, it really worked. I tolerated it quite well, let's try that again. So we can see years of drug information for you. And it's actually pretty it wouldn't be straightforward for you, but it's very straightforward for us. So, yeah. Each person has their own file, so yeah. Is that what you mean?
Yeah, no, exactly.
Yeah. So book a meds check and we can. Shameless plug. Yeah.
Do you have an opinion about whether or not seniors should be getting COVID vaccines right now?
Ooh. I also didn't anticipate that question. So if you've had COVID and you know you've had COVID in the last 3 to 6 months, you probably don't really need a COVID-19 vaccination at this time. You would have, in addition to all the other vaccines you may or may not have received, you would have developed some innate immunity to COVID based on the recent infection. I think there are certainly groups of seniors that should be trying to keep up with their COVID-19 vaccination. COVID-19 is still very prevalent in our community, unfortunately, as are many other illnesses. And certainly if you are immunocompromised, I think that's one area of individuals that should be routinely get a COVID-19 vaccination if they're eligible. If you're going into hospital, that would be another reason, I think, like for an elective procedure, for example. If you are traveling on an airplane and you are worried about contracting COVID-19, get a COVID-19 vaccine booster because everyone comes back with COVID-19. Airplanes are vessels for infection. It's why we're talking about measles right now, right? So we anticipate a huge influx of measles over the next 1 or 2 months after all the March traveling, unfortunately. So those, I guess, if you were immunocompromised or you had a planned admission to a hospital or you're traveling, I would certainly recommend a booster dose of your COVID-19 vaccine. Any other questions at all? Yeah.
As an internal pharmacist, how do you go about advocating for to add more items or ailments to the minor ailment list? Like you said, the Atlantic province's pharmacists have like twice as many.
It's incredible. Actually,
so how do they do that, and what is Ontario do?
So we are all members of our professional association, the OPA, the Ontario Pharmacists Association, and they actually have really stepped up to the plate. They've been advocating, as I mentioned, for 20 years, but in the last 4 years, I think there's been a lot of recognition by a lot of different stakeholders about the value of your pharmacist. So currently, our OPA is really, really pushing it, meeting at the table with the Ontario government, which is ultimately the group that needs to pass regulations for us to be able to provide those services for our patients. But I would say mostly through advocacy efforts through our professional association and through things like today, where our pharmacist group reach out to the community and try to demonstrate the value of what we can provide, then our patients and our communities can take that back to their legislators and help us push a little bit more too. It's exciting. I'm hopeful. So. Is there any additional questions or? Great, well, I will leave it at that, and thank you so much. Thank you for the wonderful questions, that was wonderful. And happy Pam. March of every year is Pharmacy Appreciation Month, so appreciate we're a pharmacy team. We are a team, and we do silently kind of in the background celebrate our achievements every March. And it just so happens I was asked to speak today, so happy Pam.
I'm going to ask Jill to step down here for a moment, and we have a tradition in this church of providing gift baskets, and the kind folks of the congregation have put together some items that are locally grown, for example, honey or maple syrup, and so it's my pleasure to present that to you.
Oh, that's right up my alley. Thank you.